Good morning, everybody. My name is Dr. William Kevin Kelly from the Sydney Cancer Center at Thomas Jefferson University here at the Genitourinary section. I'm joined with Dr. Kim. Dr. Kim, welcome, and can you introduce yourself?
Thank you, Dr. Kelly. This is Joseph Kim, medical oncologist here at Yale Cancer Center. I specialize primarily in prostate, bladder, and some renal cell carcinomas, and also in phase 1 program here at Yale. Thank you for having me.
Yeah, so we had some interesting sessions today. We're going to review some of the prostate and bladder abstracts here. We have some questions coming in. Joe, do you want to ask them?
Yep. So, again, really a great presentation, Dr. Kelly, about the updates on, prostate studies. And I think that one of the interesting study was that the one at the plenary session, the Vision trial. So the question actually comes from me. So, the lutetium 177 lutetium PSMA is probably going to be approved by the FDA in near term, we hope. If this is approved, what do you see this being implemented in our practice? We can talk in many different settings, but what is your view on the use of lutetium PSMA in our clinical practice for MCRPC?
Yeah, I think the lutetium PSMA is really a breakthrough for prostate cancer. Unlike radium-223, it's a non-specific directed radiotherapeutic. PSMA is directly targeted to the tumor itself. Remember, radium-223 will only go to osteoblastic lesions in the bone, and it spares soft tissue disease. Now you have a radiotherapeutic, not only will target the bone disease, but also any soft tissue disease. Again, is that tolerability is very well tolerated overall. And I think there's going to be a huge uptake in the prostate community to use lutetium PSMA. And the caveats are is that whether or not you're going to need a PSMA scan to confirm the target or not is one of the issues that is being debated right now. But again, is that you saw in the studies that 87% of patients who were applied there actually had the PSMA uptake. So it's fairly widespread in most prostate cancers. Where it's going to be used is a different question. Right now, it was really on a third line, second or third line, depending on if you use chemotherapy up front with hormone-sensitive disease. So I think that there are ongoing studies that will move up earlier and earlier and look at combination therapies. So I think that we are just in the start of learning how to use lutetium PSMA. And I do think that, there are other radio ligands using PSMA construct that will be coming down, which have different toxicity profiles, which will be very interesting in the future.
Mm-hmm. Yeah. How about for the participants, what are the common side effects that one should be looking out as we begin to use this agent?
Yeah. Like all agents, they have off-target side effects. I think, the dry mouth has been one of the biggest things they had to, really overcome. It's really, there's difference between the large PSMA and the larger molecules in PSMA there and how their distribution goes. But basically, dry mouth, you can still have myelosuppression there. Fatigue, of course, is one of the side effects. But they're all very controllable. And it's also probably going to depend a little bit about, your prior therapies. So sequencing of when to use these agents is going to be very, very important.
Good, thank you. All right, and there's another question on the PEACE-1 study. The PEACE-1 was a study that was presented by the French group, Dr. Fizazi. And, this was done primarily in the European countries, and they use ADT plus docetaxel as a, control arm, and they really test the role of adding abiraterone in the study. I know there is multiple arms there, very complex study design, but do you think that the control arm that was used is reflective of the practice here in the United States?
I think that, we have, in the United States, we have gone away from the chemotherapy with ADT up front there. And I think, we're using more abiraterone acetate, enzalutamide, or other AR-directed therapies with a ADT up front. In Europe, it was developed very quickly as a standard of care because the cost differences between the drugs, the second line AR-directed drugs versus docetaxel, you can give it much cheaper there. So they adopted that very quickly as their standard of care. Again, there's a lot of interesting things about the PEACE-1 trial and how it actually reflects the United States population. I think one of the most striking things I found in that trial is the median PSA in those arms were only 10 and 14, all right, for patients with diffuse metastatic disease. That's not the population we see in the United States. Our median PSA is a lot higher. So we really are looking at different populations between Europe and the United States. Why is that? Don't know. Some speculate that they have a higher screen rate for prostate cancer, which may be picking up the higher risk patients earlier with lower PSAs. That's one possibility. But we have to be careful when we compare one population over against another one. But it still provided, PEACE-1 trial was still a great trial and gave us some additional information. And there's multiple other trials coming down, such as the Arizonus trial, which will give us more information about chemotherapy and our doublet versus triplet combination like we saw in this PEACE-1 trial.
Yeah. I mean, there are a lot to be said about the trial, really. You make a very good point about the baseline PSA value, but it was interesting that they did not look at the subgroups. Unless I missed something, they didn't look at the subgroups of like high burden disease, low burden disease, our like framework of approaching our patients here. But I think, at least in my view, like for patients with high burden disease, the patients we're thinking about giving chemotherapy, maybe adding, abiraterone in their patient population may benefit. But, I don't think we can get away from this, idea of high burden versus low burden disease in choosing therapies for our patients. And what are the other trials that are coming up to tell us better about, this, first-line therapy for hormone-sensitive prostate cancer?
Yeah, I mean, there's a lot of trials ongoing, and I think that's what's important. Also, what happened in the PEACE-1, remember, it was on progression-free survival is the endpoint there. Overall survival was not. If you look at the ECOG study that was also presented, PFS was also improved while overall survival is not. So I still think it's very important to see overall survival, because how you sequence agents may make a tremendous difference, and not always giving more upfront is going to improve overall survival. So even though progression-free survival is important, I still think that we need to see overall survival in a lot of these trials.
Yeah. Very good. All right, let's go through some questions. There was a question about some bladder cancer in the Javelin study. You want to ask that question?
Yeah, I mean, there's a question here. Were there any other bladder sparing trials presented at this meeting that really will change standard care or start leading towards standard care changes?
I think that's a very good question. As we all know, the standard of care for most invasive bladder cancer is neoadjuvant chemotherapy followed by cystectomy. We have not been able to get away from this concept, but we all, at the same time, we all know that there are subgroup of patients who really derive benefit from bladder sparing approach with a chemoradiation, and what Gelsky and his colleague did is that they used just systemic treatment, chemotherapy with nivolumab, to see if they can improve the efficacy of the systemic treatment, and they show about nearly 50% complete response rate, and many of these patients were able to spare their bladder. Although I have to say about 30% of the patients ended up developing local recurrence, and they were able to manage the local recurrence and still be able to save their bladder for a period of time. But there also were two other studies which I did not discuss at this meeting, but there are two other studies that were presented at ASCO. Both of these studies used radiation as a backbone. And I think that this is a really important part of the regimen for bladder screening approach, because local radiation can clearly reduce the risk of local recurrence. And one study was presented by Dr. Arun Bala from NYU. He used pembrolizumab with a concurrent chemotherapy. I think he used a GemCis and the hyperfractional radiation treatment. So he used whole triplet treatment, IO, chemo, and the radiation. And he showed that complete response rate of nearly about 70–80% response rate, and that many of these patients will again save their bladder for about a year or so. So I think we need to kind of look at the long-term follow-up data for this study to really say much of the benefit of this approach. And the other study was presented by the Spanish group. I forgot the name of the study, but they used durvalumab and the tremelimumab, PD-1 and the CTLA-4 antibodies in combination with the radiation to the bladder and the minor pelvis. They did not use chemotherapy in this. In a way, they were asking the question of whether these IOs could be radiosensitizing or not. So again, in this study, durvalumab with radiation, again, they show nearly about 70–80% complete response rate as well. So again, both of these studies, we need to wait for the long-term follow-up to see if they can truly spare their bladder for long-term and eventually have a cure of their bladder cancer. So I think these are very interesting studies and potentially, paradigm shift. If they can show, bladder intact survival for long term. Again, that's still up in the air as to what does that mean, But again, there are a lot of efforts in using these agents for another cure options.
Yeah, and I think that long-term follow-up is going to be important for all those trials at this point. Looking at the relapses and how a proportion of relapses there. There's a couple questions on renal cell carcinoma. One is on the pembrolizumab and ixazomib trial, included a non-clear cell renal cell carcinoma. How do you choose between pembro and ixazomib versus cabo versus nivo combinations? I think that's a question we all ask all the time. How do you approach that? Dr. Kim?
So that's a very good question. So just to clarify the question, so for like non-clear cell RCC, the cabo-nivo, the small phase 2 study presented by the Sloan Kettering group, they showed nearly about like 50% response rate. And just as a backup, axi-pembro has been a standard of care for first-line metastatic RCC, and the cabo-nivo also per the Checkmate 9ER study is also another first-line trial options too. And I think that given the activity from this phase 2 study showing about 50% response rate, I would think that for non-clear cell histology, I think a little more evidence to support the cabo-nivo approach. And also another thing is that Dr. Monty Paul at City of Hope presented the PET-MET study using cabo monotherapy for papillary renal cell carcinoma, and showing a superior PFS and really superior response rate compared to sunitinib in that small phase 2 study. So cabozantinib clearly has activity in the non-clear cell RCC, primarily in the papillary RCC. So I tend to favor cabo combo approach for non-clear cell papillary RCC. What was interesting about that study from Sloan Kettering is that for chromophobes, there were no meaningful activity for chromophobes. So I think there are a lot more work to be done for chromophobe RCC in terms of finding a good first-line therapy options. But I tend to favor cabo-nivo for papillary RCC non-clear cell subtypes.
Yeah. All right. Yeah, I think that it's really what you're comfortable with that too. I think that both have advantages and disadvantages of those combinations, but as we've shown, combination upfront is actually the way to go for renal cell carcinoma. And another question here is Toracel. Is there still a role for Toracel in renal cell carcinoma?
Yeah, good question. I don't know. I haven't used Toracel for a long time. I think it's a blessing to have a lot of treatment options for metastatic RCC nowadays. As you mentioned, IO combination seems to be the way to go. For Toracel, the indication for Toracel was for really a pro-risk, metastatic RCC in second or third line setting, in really nearly about second line setting in the study that were used. I guess if patients use also all the systemic treatment options, maybe a consideration, but this is not really commonly used anymore.
Yeah, I occasionally use it in somebody third, fourth line therapy that has good prognosis, and you want to try a different class of agents. But I agree with you, Dr. Kim, is that some of these single agents have been falling off to the wayside a little bit. And there's a, go ahead.
Mm-hmm. No, I think there's a question for you, Dr. Kelly, about bone protective agents. Question is, how long do you recommend using a bone protective agent?
Yeah. I mean, this it's really been controversial a little bit in the literature, but typically is that most people use it for 2 years and discontinue it, especially in the castrate-resistant setting. I just find as longer we go on, more complications you get. You really have to keep on these patients about dental hygiene. Our practice is nobody gets a bone protecting agent unless they've seen a dentist beforehand and been cleared by a dentist, because we do get a lot of osteonecrosis of the jaw, which actually starts off very slowly. But if you don't keep on top of that, that can be a chronic disease, and it's actually quite debilitating at the end stages. So I'm very careful about that. But I try to use it for around 2 years. I keep on top of it. Whether you give it at monthly or every 3 months is debatable. I typically spread it out a little bit if I can. But I think the importance of the PEACE-3 trial is it is critically important for patients with metastatic castrate-resistant prostate cancer to be on a bone protecting agents, because the risk of fractures is greatly decreased with the use of it. And but you still have to screen the right patients and do the correct thing for patients. And another question came up: do you use this denosumab every 3 months? I do. Literature is scattered on the use of every 3 months, but I think that I do that every 3 months just out of convenience sake, more for the patients, because they are more consistency instead of having to come in on a monthly basis. I typically pair it with their GnRH analog. So it is very set that way. Every 3 months, they get a combination of both. That way, increase the compliance across the board. And, for me, it simplifies things. And that way, I make sure the patient does get it. Just a practical issue for me. How do you do it, Dr. Kim?
Yeah, same here as well. Every 3 month interval. To sometime if they're on chemotherapy, every 3 to 4 week schedule as well. But I agree with you. Every 3 month interval makes things much easier, and and increase their compliance with this.
Yeah.
Mm-hmm.
Great. Dr. Kim, do you have any closing remarks for the?
Yeah, no, I think, this year's ASCO was really, we learned a lot of new information from this annual meeting, especially in GE malignancies. We had two plenary sessions, two plenary presentations, the VISION trial and the PEACE-1 study, and also, the adjuvant pembrolizumab study as well. So, I think we are really beginning to understand how we use these new agents, in our practice. So I think there are a lot of potentially practice-changing presentations we saw.
Yeah, I agree. I mean, while we were all virtual this year, I still think there was a lot of presentations that were very impactful. The PEACE-1 trial was good. The VISION trial is practice changing, and we'll have a new drug for prostate cancer. And I think a lot of the trials that are coming out that are large phase 3 trials in prostate, bladder, and renal cell carcinoma, and we're continuing to have new data evolve, which is incredibly important. And so I look forward to next year's ASCO and more data coming, because I think it's exciting to see the patients live so long today.
We can meet all in person. Yep.
Yep. Well, I want to thank everybody, Dr. Kim, for joining us today, and I wish everybody a great day. And if you have any further questions, please do not hesitate to email or let us know, and we'll get an answer for you.